Hello and welcome to Lecture 16 of the Foundations of Artificial Intelligence. Today we're going to be talking about a variety of existing biomedical expert systems. In our last lecture, we covered the topics of probability and uncertainty. We began with basic probability theory, then discussed statistical inference, followed by independence assumptions, then likelihood ratios, certainty factors, and gave you an initial look at uncertainty in expert systems. Today's lecture is going to start out by looking at some different clinical decision support systems, and then we'll take a closer look at the very first expert system called DENDRAL, and this will lead into a discussion of MYCIN, one of the earliest and best known expert systems targeting a biomedical problem. Then we'll conclude this lecture by covering the basics of a variety of expert systems so you have a better idea of what's already out there. So the objectives of today's lecture are to give you exposure to some specific expert system applications with particular emphasis on medical examples. This could offer some inspiration for final projects if you want your final project to target expert systems. It also offers a more general review of knowledge-based systems and expert systems, again placing specific emphasis on those related to medicine. It also includes a detailed walkthrough of one of the first real-world expert systems, that of MYCIN, and of course to survey other select examples of expert systems. Moving into this lecture, it's important to rehash the notion that there's no universal blueprint for creating a knowledge-based system. Most of these examples have been tailored to the needs, limitations, and assumptions of that given application. To throw in a little bit of ancient history, there's a 3,700-year-old ancient Egyptian medical text called the Edwin Smith Papyrus, which was named after the dealer who bought it in 1862. This document offers the oldest known formally written surgical work on trauma. It also happens to be possibly the oldest example of a biomedical, rule-based knowledge system out there. This document describes 48 cases of injuries, fractures, wounds, dislocations, and tumors. In it, following the examination, are the diagnoses and prognoses, where the physician judges the patient's chances of survival and makes one of three diagnoses. This is an ailment which I'll treat, this is an ailment with which I will contend, and this is an ailment not to be treated. There's a fixed format here for each problem description that goes title, symptoms, diagnosis, prognosis, and treatment. The title might include something like instructions for treating a fracture of the cheekbone. The symptoms might be something like, if you examine a man with a fracture of the cheekbone, you will find a salient and red fluxion bordering the wound. The diagnosis and prognosis might say, then you'll tell your patient it is a fracture of the cheekbone and it is an injury that I will cure. And lastly, the treatment might look like this. You shall tend to him with fresh meat the first day. The treatment shall last until the fluxion resorbs. Next, you shall treat him with raspberry, honey, and bandages to be renewed each day until he is cured. This incredibly early example effectively lays out a blueprint for what is today a modern diagnosis expert system, where a clinician or user can put in symptoms as inputs, which can trigger certain rules in an expert system, leading to an output of a diagnosis. So now let's take a look at clinical decision support systems. First, what are some of the major healthcare data challenges? Here's a quote from Dr. Joe Kimura. The amount of information we need to understand is getting so untenable that it's unreasonable to expect the average clinician to integrate all of it into their decision-making effectively and reliably. This quote captures the spirit of one of the main challenges to which artificial intelligence systems into medical research and practice can be of value. What we need are tools that are designed to sift through enormous amounts of digital data that can suggest next steps for treatments, alert providers to available information that they may not have seen yet, and catch potential problems, for example, dangerous medication interactions. The term Clinical Decision Support System, or CDSS, is a general term used to reference different biomedical systems. These can be knowledge-based systems, such as expert or rule-based systems like we've covered, or they can be non-knowledge-based systems. The goal of a clinical decision support system is to link health observations with health knowledge to influence health choices by clinicians towards improved healthcare. Knowledge-based CDSSs include things like diagnosis decision support systems, treatment decision support, case-based reasoning systems, medical alert systems, including physician order entry systems, which might do something like warn about allergies, or patient monitoring systems. And then there's also reminder systems, which might be useful in outpatient care. On the other hand, non-knowledge-based systems might include things like machine learning systems, or hybrids of knowledge-based systems with machine learning. One useful way to classify different clinical decision support systems is to do so based on the timing of its use. Doctors can use these systems at point of care to help them as they're dealing with a patient. This can be at pre-diagnosis, where they're useful to help the physician prepare the diagnoses, during the diagnoses, to help them review and filter the physician's preliminary diagnostic choices to improve their final results. And of course, post-diagnosis, where they can be used to mine data to derive connections between patients and their past medical history, as well as clinical research to predict future events. One clinical decision support system that we've mentioned is a Diagnosis Decision Support System, or a DDSS. Such a system will request some of the patient's data, and in response it'll propose a set of appropriate diagnoses. The doctor then takes the output of the DDSS and determines which diagnosis might be relevant and which are not. And further, if necessary, to order further tests to narrow down that diagnosis. Again, this isn't meant to replace a physician, simply to supplement and improve their diagnoses. Differently, a system for treatment decision support, or a TDS, might be useful in the case where patients are often unaware of the benefits, side effects, costs, or other key factors about a healthcare treatment that may inform their decision as a patient. For example, a cancer patient may face a decision whether to pursue aggressive chemotherapy to prolong life versus more palliative therapy to increase quality of life. A TDS can help patients to actively engage in the healthcare decision-making process by gathering and weighing information which may be personalized for their situation. So in other words, such systems can facilitate the tailoring of treatments in a way that takes patient perspective into account. And such systems can help improve communication pathways between patients, caretakers, and clinicians to better identify care priorities. Another CDSS worth defining includes case-based reasoning systems, or CBRs. In general, these methods focus on the process of solving new problems based on the solutions of similar past problems. They might use previous case data to help determine the appropriate amount of beams and the optimal beam angles for use in radiotherapy for brain cancer patients. Here, a medical physicist and oncologist would then review the recommended treatment plan to determine its viability. Next, we have reminder systems as another CDSS. These are generally simpler knowledge-based systems that automate actions with respect to patient scheduling, taking medication, or in other words, encouraging adherence in patients, or obtaining patient follow-up data. Next, let's talk about electronic health record applications, or EHR applications. Many believe that EHRs are the way of the future for the healthcare industry. They are a way of capturing and utilizing real-time data to provide high-quality patient care and ensure efficiency and effective use of time and resources. There's a great potential to incorporate electronic health records and clinical decision support systems together into the process of medicine, and this has the potential to change the way that medicine has been taught and practiced. 3 areas that can be addressed with the implementation of CDSSs and electronic health records are medication prescription errors, adverse drug events, and other medical errors. However, it's useful to note that the measurable benefits of clinical decision support systems on physician performance and patient outcomes remains itself the subject of ongoing research. Another CDSS is a medical alert system. For example, as we heard earlier, this could include a physician order entry system or a patient monitoring system. Medical alert systems are often integrated into the electronic health record to streamline workflows and take advantage of existing datasets. Many organizations are still facing significant challenges when it comes to creating intensive, user-friendly, and effective protocols for alarms, alerts, and decision-making pathways. Another issue that comes up often with medical alert systems is that of alert fatigue and clinical burnout, which are common byproducts of poorly implemented clinical decision support features that overwhelm users with unimportant information or a frustrating workflow that requires extra clicks on the part of the physician to circumvent. Alert and alarm fatigue consistently make industry lists of health IT hazards and patient safety, with experts like the ECRI Institute warning that users can quickly become desensitized to critical alerts when inundated with too many low-priority pop-ups, sounds, or messages. Let's walk through a handful of promising specific use cases of CDSSs. A hospital in Alabama decreased sepsis mortality rates by 53% with the use of a computerized surveillance algorithm. It conducts real-time analytics to alert providers to new diagnoses of sepsis or worsening vital signs. It also provides reminders about best practices for treating patients with the deadly condition. At the Mayo Clinic, they have computerized decision software that helps nurses deliver complete and accurate phone screenings of patients seeking advice or appointments. The software also guides triage nurses through a series of standardized questions based on current care guidelines. This is to ensure that they don't miss important information about the patient's health. At the Harding University, as well as Unity Health White County Medical Center, they combined a CDSS with genetic testing data and found that they could reduce hospital readmission by 52%, as well as reduce emergency department visits by 42%. This also included conducting drug-drug and drug-gene interaction testing on high-risk patients to help produce an estimated cost savings of more than $4,300 per capita. At the Yale and Mayo clinics, on patients that present with head injuries, they use industry guidelines to provide information to patients while evaluating the severity of the injury. The system they use explains decision treatments to patients while potentially reducing the number of unnecessary CT scans, which is a high-cost test that's not always warranted. Another example comes from the Department of Veterans Affairs in Indiana. This site uses tools geared towards reducing unnecessary lab utilization, which helped decrease total test volume by 11.18% per year and generated a cost savings of more than $150,000 without impacting care quality. So as you can see from these examples, the development and utilization of clinical support systems is often about improving patient care while reducing costs. Some other possible applications of CDSSs including completing drug dosing calculations, assessing drug formulary guidelines, using severity indexes for specific illnesses, tailoring ordered sets or templates for specific diseases, identifying reportable conditions based on EHR inputs, using time-triggered reminders for medication delivery or dosage changes, identifying needed preventative care screenings or care gaps, including monograms, colonoscopies, and flu shots, or accessing filtered reference information or educational materials. Clinical decision support systems are increasingly leveraging machine learning and artificial intelligence to power sophisticated analytics. Machine learning algorithms can ingest large quantities of data, identify patterns, and return detailed results to users. UPenn utilizes machine learning powered by a CDSS tool that reduces the time to detect sepsis by 12 hours, which could be the difference between life and death in many patients. This algorithm used data from more than 160,000 patients for training and was validated on a holdout sample of a further 10,000 individuals. At MIT, they have a deep learning tool that uses bedside monitors, clinical notes, and other data sources to generate hourly predictions about ICU patients in order to give providers a head start on altering their care plans for highly complex patients. At this point, we're going to start to transition into thinking about expert systems in particular as a medical AI system. First, we'll quickly review some of the earliest successful expert systems. The very first was DENDRAL, developed by Feigenbaum, Lederberg, and Bachmann in 1965. This system deduced the likely molecular structure of organic chemical compounds from known chemical analyses and mass spectrometry data. Another subsequent famous expert system is MYCIN, developed by Buchanan and Shortliff between 1972 and 1980. This system focused on the diagnosis of infectious blood diseases and a recommendation for the use of antibiotics. This work also led to one of the first expert system shells, which was called EMYCIN or EMYCIN. Another early successful expert system is that of Prospector, designed for the analysis of geological data for minerals. Using this system led to the discovery of a mineral deposit worth $100 million. And another system, XCon/R1, was developed by McDermott in 1978. This system was designed for the configuration of DEC VAX computer systems and included 2,500 rules and had processed 80,000 orders by 1986, leading to a savings of $25 million a year. Next, we're going to take a closer look at the first expert system called DENDRAL. The DENDRAL system, which stood for Dendritic Algorithm, was the first expert system, and it was developed in the 1960s. Again, this automated the decision-making process and problem-solving behavior of organic chemists. It was written in Lisp, which at the time was considered the language of AI, And the idea behind it was that given mass spectrogram data, can we determine what the chemical composition was? The project itself consisted of research on two main programs, heuristic DENDRAL and MetaDENDRAL. Notice as we go through this that this first expert system is very much customized to the problem at hand. What's also interesting about DENDRAL is that it was an expert system designed with human feedback in mind. It followed an approach that took a plan, generate, test cycle. So first, generate a hypothesis, in other words, a possible chemical compound, then test the hypothesis by using a series of heuristics and subprograms to determine if the chemical compound generated is plausible given the data. Then, if it was plausible, show it to the user, and the user can steer the direction of DENDRAL by suggesting what chemical elements should be added or removed from the generated hypothesis compound. DENDRAL repeats this process until an answer is found that is acceptable and does not violate the constraints as dictated by the data. This table summarizes the algorithmic components behind the DENDRAL system. Up here at the top is the heuristic part of DENDRAL, or heuristic DENDRAL, and down here is MetaDENDRAL. Heuristic DENDRAL includes algorithms that handle planning, generating, and testing, with different input information and output information given for each. MetaDENDRAL includes planning, generating, and testing, again with inputs and outputs delineated. I don't expect you to come away with a full understanding of how DENDRAL works, but if this is something that interests you, feel free to explore any specific expert system in more depth on your own. The heuristic part of DENDRAL includes a performance system. Here, the input includes mass spectra or other experimental data. It uses a knowledge base filled with hard-coded information about chemistry, and the goal of this subcomponent is to produce a set of possible chemical structures that may be responsible for producing the data. So, for example, water has a molecular weight of 18 since hydrogen has a mass of 1.01 and oxygen 16, and thus its mass spectra has a peak of 18 units. The system might use this input mass and the knowledge of atomic mass numbers and valence rules to determine the possible combinations of atomic constituents whose mass would add up to 18. Of course, as the weights increase and the molecules become more complex, the number of possible compounds increases dramatically. Thus, a program that is able to reproduce this number of candidate solutions through the process of hypothesis formation becomes essential in practice. DENDRAL is a rule-based expert system, and here's an example of a rule that you might find within DENDRAL. If the spectrum for the molecule has two peaks at masses x1 and x2 such that, and here are some of the conditions with variables in them, then the molecule contains a ketone group. And here the peaks are referencing this mass spectrometry graph here on the right. Basically, we can combine facts from the spectrogram as well as relationships from the rule base to identify the presence of necessary substructures or forbidden substructures. Another rule we might find in this system is something like if there's a high peak at this number and any peak at 58, then this compound is a necessary substructure. As you might imagine, there are a huge number of possible rules that could underlay this expert system. Shifting to the other part of DENDRAL, or MetaDENDRAL, this is primarily a learning system. It includes a machine learning system that receives the set of possible chemical structures and corresponding mass spectra as input and proposes a set of rules and mass spectrometry that correlate structural features with processes that produce the mass spectrum. These rules would then be fed back to the heuristic DENDRAL to test their applicability. Here's a small sample of possible output from the DENDRAL system, in this case proposing some functional subgroups that might exist on our target chemical compound. So we have the compounds over here on the left, and we have the rules on the right that were triggered suggesting the occurrence of these subcomponents. We'll end this brief overview of DENDRAL by pointing out that as the first expert system, it was the inspiration for many other expert systems that were structured in some way based on how DENDRAL was set up. One of the closest descendants of DENDRAL was MYCIN itself. Now we'll shift gears and talk about the MYCIN expert system. A little bit more background on MYCIN. It was an expert system designed for the diagnosis of about 100 bloodborne infectious diseases. It uses test results and information about patients supplied by the doctor and outputs a prescription for an effective antibiotic treatment. The system was designed to be used early in the course of disease before all possible information might be available. It was also designed as a strategy to hopefully counteract the overuse of antibiotics, the irrational use of antibiotics, or the maldistribution of expertise. The name MYCIN comes from the fact that most drugs used in the treatment of bacterial infections are something called something mycin, such as erythromycin. Traditionally, such diagnoses were derived from symptoms and from growing cultures of the infecting organisms. Doctors had to come up with quick guesses about likely diagnoses and treatments. This system was developed to explore how doctors make these rough but important guesses with partial information. Using this system in practice could also be important since many junior doctors or non-specialized doctors might struggle with such diagnoses. Ultimately, MYCIN was intended as an advisor for doctors when treating patients, or again, to extend, not replace, the expertise of a doctor. However, despite its fame, MYCIN was never actually used in practice, and it was not due to its performance, but due to concerns about ethical and legal issues. Let's take a look at some key facts about the MYCIN expert system. First off, it was written in interLISP, and it included an if-then rule base of 450 expert rules. These rules were acquired by interviewing experts. The system utilized both forwards and backwards chaining for the inference process. Further, MYCIN carries on a text-based dialogue with a physician. And importantly, MYCIN is also capable of dealing with uncertainty. After its development, MYCIN was tested to see how effective it was. Starting from 10 therapy recommendation problems, these were handed to a panel of therapy recommenders, the MYCIN expert system, and compared to the original recommendations for these problems. These recommendations from different sources were then combined and shuffled so that a panel of judges didn't know which recommendation came from which source. And then this panel of judges decided if each group of recommendations was equivalent, acceptable, or not acceptable for a given problem. This study showed that MYCIN performed as well as some experts and considerably better than junior doctors. So obviously there was some clinical value to this even very early expert system. Recall from our earlier lecture this schematic of a general expert system. As we'll see in a moment, the MYCIN system includes a lot of these same components. Here's a schematic of MYCIN, not quite organized in the same way of the schematic, but we have our knowledge base over here on the right. Included here is a static database including rules, parameter properties, and some other information. Up here we have our inference engine, which is called a consultation system in MYCIN. We have an explanation system, and a knowledge acquisition system, which can also be thought of the knowledge base editor. Over here we have the dynamic database, so these would be our case-specific facts being added to our database over here on the left. The MYCIN expert system decision process takes 4 stages. First, determine the identity of the organism, or at least a range of possibilities. Here the physician obtains samples from the site of the suspected infection, such as blood, aspirate from abscesses, throat swab, or urine, and this is sent to the lab for culture. Early evidence back might include morphological, staining characteristics, etc., but the complete testing of the sample usually requires 24 to 48 hours, if not more. Next, the system decides whether the patient has a significant infection requiring treatment. This involves information about the seriousness of symptoms and the likelihood of infection. Next, MYCIN tries to select a set of drugs that might be appropriate given the identity of the organism and whether the infection was significant or not. This is useful because even when the organism is known, the range of antimicrobial sensitivities might not be by the clinician. And further in vitro sensitivity tests can take another 24 to 48 hours. Thus, drugs might need to be selected based on statistical data of antimicrobial success. The last decision phase of MYCIN is to identify the most appropriate drug or combination of drugs from all the possibilities. This can be based on success stats, the route of administration, or the severity of disease. Notably, with the availability of more definitive information, the decision of the drug choice or dose might change. MYCIN also incorporates what are called meta rules or high-level control rules that are implemented to manage this overall 4-stage decision process strategy. While MYCIN conducts both forwards and backwards chaining, its primary direction is a backwards chaining system. And thus MYCIN starts out with a control rule that says if there's an organism requiring therapy, then compute the possible therapies and pick the best one. Thus, the query is to compute the possible therapies and pick the best one. This control rule generates sub-goals. The first sub-goal is there an organism that needs to be treated, including is the organism already known, and if not, conduct the reasoning process to begin identifying the potential organism or organisms. Further, do the symptoms suggest bacterial infection? And if so, it'll generate the next subgoal. Here, subgoal 2, is the organism significant? In other words, meriting treatment. This will provoke questions to the user. When the user answers these questions, it allows other rules to be fired. This in turn can lead to further questions being asked by the system as needed. Eventually, the if part of the control rule gets satisfied, and the then part compiles a list of drugs and chooses from it. So here is that control rule in MYCIN. If there's an organism which requires therapy, and consideration has been given to possible other organisms which require therapy, then compile a list of possible therapies and determine the best therapy. Else, indicate that the patient does not require therapy. So this is that highest level control rule from which backwards chaining will progress. Regarding the subgoals, at any given time, MYCIN is establishing the value of some parameter by subgoaling. MYCIN does give the opportunity to bypass having to go through subgoals by following a path whose certainty is known. And this can be used to make a quick, definite conclusion. So maybe that information is already a fact in the fact base, or the user provides it definitively in response to a question being asked. So again, these utility paths won't allow us to avoid searching a subgoal if it can just be obtained from a user. Let's take a closer look at the syntax or the representation of rules in MYCIN. First off, the rules have no variables, but apply contexts instead. So in other words, MYCIN dealt with a number of implicit variables. For example, there could be a patient, a culture, and a few infectious organisms. Thus, MYCIN's knowledge is structured into object, parameter, value triples. So for example, culture could be an object, site might be a parameter of culture, and a possible value of this parameter would be blood. Next, let's take a closer look at the backwards chaining process in MYCIN. We identify all rules that can provide the conclusion currently sought, where the initial conclusion is called diagnose and treat. Any rule that can conclude this is added to the list of rules to test. Each of these rules is used to match their premises against the working memory. Any of these rules that are true, in other words, their parameter value matches, are fired. These rules' conclusion is an action used to modify the hash table. In other words, either add a new piece of knowledge to the hash table, or find and remove a piece of knowledge which is no longer needed, or find and modify a piece of knowledge now that more specific information is known. So here's an example rule from MYCIN. If the site of the culture is blood, and the gram of the organism is negative, and the morphology of the organism is rod, and the burn of the patient is serious, then there is weakly suggestive evidence, confidence factor 0.4, that the identity of the organism is Pseudomonas. Here's another example. If the identity of the organism is not known with certainty, and the gram stain of the organism is gram negative, and the morphology of the organism is rod, and the aerobicity of the organism is aerobic, then there is strongly suggestive evidence that the identity of the organism is Enterobacteriaceae. Here we can see how MYCIN defines these qualitative certainty factor phrases within the system. For example, certain evidence would have a certainty factor of 1.0. Strongly suggestive evidence, like we have in this rule, would fall between 0.8 and 1.0. Suggestive evidence would be above 0.5 to 0.8. Weakly suggestive evidence would be between 0.0 and 0.5, and no evidence either way would be a certainty factor of 0. Notably, MYCIN rules do allow ors in them. So here's an example of a rule with or conditions. If the therapy under consideration is cephalothin, or clindamycin, or erythromycin, or lincomycin, or vancomycin, and meningitis is a diagnosis for the patient, then it is definitive that the therapy under consideration is not a potential therapy. Notice that we have rules about both treatment as well as the diagnosis. MYCIN also includes a rule with ors in its consequent, or the then part of the rule. If the identity of the organism is bacteroids, then the recommended therapy can be chosen from among the following drugs. This, or this, or this, or this, or this. MYCIN also includes therapy rules. Here's an example. If you're considering giving chloramphenicol and the patient is less than 1 week old, then it is definite, in other words, a 1 certainty factor, that this drug is contraindicated for this patient. Further, because MYCIN allows dialogue between the expert system and the user, a user could ask why this conclusion was true, and we could get a justification. In this case, newborn infants may develop vascular muscular collapse due to an immaturity of liver and kidney functions, resulting in decreased metabolism of this target drug. So far, we've been looking at MYCIN rules in this fairly human-readable format. So here we see how these same rules are actually coded within the MYCIN system itself, using the syntax of this Lisp-based coding language. Next, let's talk a little bit about how MYCIN deals with uncertainty. We've already seen a few examples of uncertainty pop up in some rules. Of course, the medical field must reason in the presence of unknown, incomplete, and vague or uncertain information. As we've heard, certainty factors are initially hard to defend from a sound theoretical viewpoint, but some theoretical foundations were later established in the work by Dempster-Schaefer. Certainty factors can be useful to see where knowledge about uncertainty exists and the implication it has for the design of the system. MYCIN maintains certainty for possible values of parameters, so ultimately the certainty that you have a particular disease, and it can maintain multiple possible values, each with its own certainty. MYCIN also maintains certainty for the validity of a rule. As we've seen in our last lecture, certainty factors can be combined to propagate across a rule chain all the way to the conclusion. Here we have the range of certainty factors in MYCIN, which should be familiar. MYCIN uses certainty factor ranges as such, where 1 is certain, 0 is we don't know anything about whether it's true or not, and -1 is a rule that is certainly not true, or a completely incorrect rule. In practice, certainty factors are assigned to rules or facts in the range of 0 to 1 and allow us to rank different conclusions, as well as to simply assess our overall certainty with our chosen conclusion. Another key aspect of MYCIN is its consultation system. This gives MYCIN some nice user-friendly features, such as a natural language interface, where users can also request rephrasing of questions. It has a synonym dictionary that allows a latitude of user responses, giving the system a lot more flexibility for users. And interestingly enough, basic typos are automatically fixed, where MYCIN will say, "Did you mean?" and propose a closer, valid text entry chosen from a list of acceptable answers to a question. The consultation system can also provide an explanation of decisions or suggestions, as well as alternative recommendations upon request. Further, questions are asked automatically of the user whenever the system needs more data. If the data can't be provided, the system will ultimately ignore those relevant rules, and instead work with what it has. So let's look a little bit more at how MYCIN might ask users for values. So depending on the type of data, MYCIN might ask the user if a value is known, and when it does this, it tries to ask the most general question possible, so as not to become overly annoying or repetitive. So for example, if MYCIN wants to know if the morphology of the organism is a rod, it'll ask what is morphology of organism, rather than ask specific questions like, is the morphology rod? Is morphology something else repeatedly? Now let's look at an example consultation with MYCIN between a user and the expert system itself in trying to make a diagnosis. So as we said, MYCIN is an iterative process. It starts running, it asks a question, the user answers it, and MYCIN asks another question. So here we start with the system asking the patient's name, and the user enters Fred Braun. The system asks for sex, the user enters male. System asks for age, 55 is entered. The system asks, are there any illnesses for Fred Braun which may have been related to the present illness and from which organisms have been grown in the microbiology laboratory? The user responds yes. Now the system asks, from what site was a specimen for culture 1 taken? The user puts in a typo of blood, and the system suggests blood instead. Then the system asks, please give the date and time when culture 1 was obtained, and this is entered by the user. The system now clarifies that the first organism isolated from the blood culture on this date, in other words culture 1, will be referred to as organism 1. Now the system asks, enter the laboratory reported identity of organism 1. The user responds unknown, perhaps because that lab test hasn't come back yet. Now the system asks, stain, gram, or Zil-Nelson acid fast of organism 1, asking for the result of that test, and the user types in negative. Then the system asks, is organism 1 rod or coccus? And the user responds rod. Now the system asks, what is the form of the individual organisms? And the user responds fusiform. Perhaps this consultation continues, or perhaps that's all the information that's needed, but ultimately the consultation should yield a possible diagnosis. So in this case, the system might report, it is important to cover for the following probable infections and associated organisms. Here the system speculates that the infection 1 is bacteremia, which could include the following organisms. Now that we've seen how the question and answer consultation works in MYCIN, let's look at the explanation system. MYCIN can explain why it's asking a question. It can also explain how it derived a conclusion, or explain why it found another result implausible. The explanation process is a tree traversal of the traced rules, where why moves up the tree and how moves down. So if at any moment the user asks why, the system tries to respond given the context of the current rule. However, if the user asks why a second time, the system will use the rule which caused the current rule to fire to try and answer this secondary why. Remember that MYCIN is primarily chaining backwards from the overall goal of showing significant disease. You can continue asking whys all the way down to the most basic facts. Here's an unrelated example of an explanation system answering why. So maybe we have a system that asks how old is the car's battery, and the user replies why. The system then responds that this will aid in determining the battery's condition. So in this case, the system was asking a question based on this rule, because it needed the value of this condition. The car's battery age is over 5 years, which is why it needed how old is the car's battery. It responds this way because this is the target condition trying to be proved. Therefore, the system has answered, this will aid in determining the battery's condition, which is the then part of this target rule. And if we ask why a second time in this situation, the system should respond, this will aid in determining the proper recommendation. In this case, we're trying to satisfy the if condition of Rule 44, which is about the battery's condition. This was the then part of the last rule we saw. So now asking why a second time moves us further along in the rule chain, and now our system justification has to do with the then of the following rule in the chain. So in other words, when the system asks how old is the car's battery and the user wanted to know why, the system replied, this will aid in determining the battery's condition. When the user responds why again, it's with reference to this answer from the system. So now the why is about determining the battery's condition, which is answered here in the second response from the system. Now let's go back to explanation in MYCIN. So here we have a question asked by the system, was penicillinase added in culture 1? The user might respond why instead of giving an answer. So the system then responds, this will aid in determining whether organism 1 is a contaminant. It has already been established that the site of culture 1 is blood and the gram stain of organism 1 is gram-positive. Therefore, if penicillinase was added to this blood culture, then there is weakly suggestive evidence that organism 1 is a contaminant. So in this case, MYCIN is explaining fully through the use of rules in the rule base why it needs this piece of information. We can ask why again, and MYCIN would respond in order to determine whether there is a significant disease associated with organism 1. It has already been established that this blood culture was taken from a sterile source. And then it also gives the rule information. Therefore, if organism 1 is not a contaminant, then there is strongly suggestive evidence that there is a significant disease associated with organism 1. We've just looked at explanation of why, but how about explanation of how? Let's go back to our battery example first. I recommend that you replace the battery. This is the conclusion of that expert system. And the user asks how. So now we're going backwards in our chaining process to answer this question. The system responds, I used Rule 44 to conclude that the recommendation is to replace the battery. So in this case, we start with our rule with the query in the conclusion, and we use the condition to answer this question of how. The system can give other information about how the condition of this key rule was proven to be true. In this case, it triggered Rule 37 to conclude the condition of the battery, which is the rule's condition here, and the rule's conclusion in this rule. When explaining how, the system will often also give the facts that were provided by the user in order to prove these rules' truthfulness all the way up to the query. Getting back to MYCIN, let's look at an example of when a user might ask for an alternative. So in this case, the user says, why didn't you consider streptococcus as a possibility for organism 1? MYCIN will then go on to explain why maybe that rule wasn't triggered. So in this case, the following rule could have been used to determine that the identity of organism 1 was streptococcus, and it points to Rule 33, and then explains, but clause 2, or condition 2, the morphology of the organism is coccus, was in this case already known to be false for organism 1, so the rule was never tried. So hopefully at this point you can see how this question and answer system really allows for a lot more transparency in the functionality of this artificial intelligence system, in contrast to most all other systems that you might have heard of or maybe even had some experience playing around with. Of course, setting up a system like this does take a lot of work and pre-thought. Now let's look at MYCIN's therapy recommendation. Here, one therapy rule is presented for each organism. So for recommendation 1, my preferred therapy recommendation is as follows. First, the therapy recommendation might point to important facts or rules in the rule base that this preferred therapy is trying to cover for. Then it explicitly gives the therapy recommendation, in this case, kanamycin with a dose of 750 milligrams for 28 days. The system can also provide comments for the recommended therapy, in this case modifying the dose in the case that renal failure occurs, and switch to penicillin with a dose of this many units for 28 days. MYCIN's therapy selection is based on sensitivity, contraindication screening, and using the minimal number of drugs while maximizing the coverage of organisms that were identified. Experts can also ask MYCIN for alternative treatments, and in this case, the therapy selection process is repeated by MYCIN, but now it's done so where the previously recommended drugs are removed from the list. We mentioned briefly earlier that MYCIN was the inspiration for EMYCIN, or empty MYCIN, also known as essential MYCIN. This was effectively the first expert system shell. It offered a pattern matching system that would mimic MYCIN's problem-solving process without the domain-specific rules. So now to build an expert, one only needed to supply a new knowledge base, in other words, the rules, and presto, you have a new expert system. Here are just some of the expert systems that were built on the EMYCIN framework, including R1, PUF, Gideon, and SACON. Now that rule-based systems had been introduced, a number of other programming languages were released that allowed quick and easy construction of rule-based systems. These were often called production system languages because a rule base is a type of production system. Most of these languages supported either backwards chaining or forwards chaining. For example, the language OPS5 uses forwards chaining and was used to develop many expert systems and included the ability to encode certainty factors or other forms of uncertainty such as probabilities. The language Prolog uses backwards chaining and applies to logic statements only. There are no mechanisms here for uncertainty and no ability to represent not. Then there's SOAR, which basically took OPS5 and added something called chunking, which was a rudimentary learning algorithm. Another language which I've mentioned previously is CLIP, which is an expert system shell language written in C++, but in practice looks a lot like Lisp, using both forwards and backwards chaining rules, as well as an estimate of salience, in other words, how useful a rule might be. Lastly, there's something called Jest. This is basically the CLIPS language that's been rewritten in Java with now GUI capabilities added to it. If you're really interested in the idea of developing a new expert system, checking out Jest as well as the original CLIPS might be the best places to start. We'll end this lecture with a tour of some other medically related expert system examples. First off, we have this table that summarizes a number of medical expert systems that have been developed over the years. For example, PUF is one that was designed to diagnose lung disease. VM was designed to monitor intensive care patients. ABEL was designed to diagnose acid-base electrolyte disorders. AI COAG was designed to diagnose blood disease. AI Rheum was designed to diagnose rheumatoid disease. Caduceus was designed to diagnose a variety of general internal medicine diseases, and a handful of others that you can check out on your own. Another expert system of note is called Internist-I, designed for diagnoses in internal medicine. It was developed at the University of Pittsburgh in the 1980s and was designed as a largely rule-based system that used forward chaining. Internist-I covers about 80% of general medicine, with descriptions of 750 disorders compiled from the medical literature and interviews with specialists. Uniquely, Internist-I applies abductive reasoning, or abduction, and it was one of the first to do so. As such, Internist-I diagnoses are seen as best or educated guesses, but neither probabilities nor a certainty of conclusions can be generated here. Internist-I includes a knowledge base consisting of disease profiles, giving symptoms associated with disease and the strength of association. So in other words, regarding the diagnosis of a echinococcal cyst of the liver, the evidence cough has a strength of 1, evidence fever a strength of 2, and jaundice a strength of 4. The Caduceus system sought to improve on MYCIN, which focused on blood-borne infections, but instead here Caduceus embraces all of internal medicine. Caduceus was founded on Internist-I and uses an inference engine similar to MYCIN. Caduceus similarly incorporated abductive reasoning, and it's been described as the most knowledge-intensive expert system in existence. The expert system Pathfinder was designed for the diagnosis of lymph node diseases. It was developed at Stanford Medical's computer science program in the 1980s. The need to create Pathfinder came from the observation that there was a large difference between expert and general pathologist opinions when it came to diagnosis, and this difference was almost 65%. Pathfinder deals with over 60 diseases and over 100 different inputs of symptoms and test results. Pathfinder was built over the course of 4 versions or phases. The first version of Pathfinder was a rule-based system that was unable to work with uncertainty. Pathfinder 2 introduced certainty factors, as well as Dempster-Schaeffer belief functions, and also found that naive Bayes outperformed all other methods that it considered in integrating inductive learning into the system. But this version was poor at excluding events the experts were sure could not happen. The third version of Pathfinder used naive Bayes with more careful elicitation of probabilities and thus performed a bit better. And then the fourth version of Pathfinder incorporated a belief network and was found to outperform experts who were some of the world's leading pathologists. The next biomedical expert system I'll mention is PUF, which performed pulmonary disorder diagnosis and was implemented using rules and the EMYCIN framework. PUF can diagnose the presence and severity of lung disease and produce reports for the patient's file automatically. PUF does not require direct interaction with a physician, thus avoiding the human engineering problem. When it comes to PUF knowledge representation, it includes 75 clinical parameters, and these represent pulmonary function tests such as total lung capacity and residual volume. PUF employs backwards chaining, as well as about 400 production rules. And it has the ability to ask the user for a response if it can't conclude the value of a parameter on its own. PUF was designed so that a pulmonary physiologist would review the PUF report and, if necessary, modify it online before printing it out for the patient's file. Notably, the report was found to be fine on its own and not require any kind of physician modification in about 85% of the cases. The basic knowledge that went into assembling PUF was later incorporated into the commercial Pulmonary Consult product, of which several hundred copies were sold in the 1980s and used across the world. Another biomedical expert system I'll mention is Centaur. This system used the same knowledge in PUF, but in a different way. Here, rules were grouped into specialized agents, and we'll learn more about agents in our next lecture. Here, one agent was assigned per each possible diagnostic conclusion. So in other words, one set of rules had ownership of determining if that conclusion was true or false. Conclusions were then grouped into a hierarchy so that a generic disease would be higher in the disease taxonomy and its children would be more specific instances. We could see an example of that down here. So Centaur had dozens of these specialized agents, each driven by rules specific to a target conclusion, rather than just a general mix of thousands of rules that made up the knowledge base. This made for a more elegant overall structuring of the expert system. A few other medical expert systems of note, we have CASNet, developed in 1978. This was designed to recognize and prescribe remedies for disease states related to glaucoma. It was developed at Rutgers University, and it used a causal association network, which is where the name CASNet comes from, in order to model characterizing the pathophysiological mechanisms and clinical course of treated and untreated diseases. Another system was called the STD Wizard, developed in 2002. This is a publicly available expert system for determining which screening tests, vaccinations, and evaluations are recommended related to sexually transmitted diseases. STD Wizard actually runs as a web browser and includes potentially over 100 questions, but most users only actually need to get asked about 20 of them. After asking all required questions, the program displays a list of recommendations relating to screening tests, vaccinations, and evaluations. Here we have the last two medical expert systems we'll talk about. The first is DEXplain, developed in 1987. This is a clinical decision support system designed to assist clinicians by generating stratified diagnoses based on user input of patient signs and symptoms, as well as lab results and other clinical findings. DEXplain could provide explanations of evidence, it could recommend follow-ups for clinicians, and it could be used as an educational tool. And lastly, ABEL from 1981. This expert system could be used for the diagnosis of acid, base, and electrolyte disorders. This system used a causal network reasoning approach, which could simultaneously reason at 3 levels of abstraction: the clinical level, intermediate level, and pathophysiological level. In today's lecture, we began by covering clinical decision support systems, talking about different knowledge-based systems such as diagnosis decision support systems or medical alert systems, and then we briefly mentioned non-knowledge-based systems such as machine learning systems or hybrid systems. Then we took a close look at DENDRAL, the first expert system, and an even closer look at MYCIN, the earliest and most famous medically inclined expert system out there. And then we took a tour of some other biomedically related expert system implementations over the years. Here's today's quote. Use your 5 senses. The art of the practice of medicine is to be learned only by experience. 'Tis not an inheritance. It cannot be revealed. Learn to see, learn to hear, learn to feel, learn to smell, and know that by practice alone can you become an expert. Just a reminder that both the final project proposal and assignment 3 are going to be due soon. Please check the syllabus for these specific dates. As always, thank you for your attention, and I'll see you in the next lecture.